thank you for, I hope now with all the technical teams around the globe. My name is David Oluoch. I'm a neurosurgeon in Nairobi, Kenya. I work with Mahmoud Qureshi. And we thought I'd just share some thoughts about endoscopic third ventriculostomy and some of the techniques in terms of avoidance of complications. I thought I'd put Ben Wolf there because he's one who's done most work really in terms of endoscopic third ventriculostomy. He was using a pediatric cystoscope, and it was a flexible one. Kenya is right next to Uganda, so it's part of our claim to fame. I started doing endoscopy here before 2006 using a pediatric cystoscope, which was from Carl Storrs. It was the only rigid scope that we had available, and I had borrowed some Fogarty balloon catheters. I started using a forceps, bronchoscopy forceps, to do ETVs, and I thought I was being clever, but Philippe Deck actually published this in the as a case report and technical notes in 2000. So after that, it was accepted that this was a way forward. Now, in Kenya, we had a watershed year in 2006 because a group of us went to the IFNE in Lyon, France. We met José Piquet and Shizuo Oi. There we see José Piquet with one of the first courses we had here. We used the Oi endoscope, and you can see how, in terms of utilizing it, some of the things that we worry about is a free-handed technique has to be stable. Now, there are actually three neurosurgeons who was watching José Piquet to stabilize it. We were told earlier how we use a sheath, and it's important that, as it is like a gun, you secure it next to your body so it does not overshoot. The first endoscopy was done. 3 neurosurgeons. There's Mulunga there, worked with José Piquet, with the Shizuo Oi endoscope. It has been secured, not a free-handed technique, and with that, José is gripping it close to his chest. They're all looking at the tower, and that's one of the techniques to make sure that you do not overshoot. Mahmoud Qureshi doing the same. Same thing, somebody securing it on the table. As he had mentioned earlier, we have excessively large hydrocephalosis. Shizuo Oi called it mega hydrocephalus, and you can see on the patient's head, it is actually trans-illuminating because there's so much fluid within it. In terms of the techniques, the irrigating tubes that we have, light source, we were shown about the use of towers, but we used the telepack system. Telepack, it has all-in-one, the screen, the light source, and there's the Oi endoscope, like a gun, and we said that this is like the 007. So this telepack system traveled around the region, and it has been published in Neurosurgery, World Neurosurgery. Both Mahmoud Qureshi and José Piquet have published that. The usefulness of it, it's portable, and you do not need the maximum tower for it to be able to work. This fits in a suitcase, and for our setup in this region, it is very useful. What I will do now, I think you had the anatomy shown earlier on by Mahmoud Qureshi. This is an example of using the Shizo Oi, we went through the sheath, entering foramen of Monroe. As I told you earlier, in our setup, we sometimes have very thick floor of the third ventricle. This one is not too bad. You can see the infundibulum of the pituitary. And that's the floor of the third. The mammillary bodies are there, widened. And in this particular, you can actually see the pulsation of the floor of the third ventricle. Now, the technique that was shown earlier, straight down, holding it next to your body, the free-handed technique is what we utilize. And for the patient's heads, we sometimes just secure them using simple tape, the 3M tape, so that the head does not move around much. In this particular demonstration, we'll be using a Fogarty catheter. Now, the Fogarty catheter that we have can fit through the working channel. If it is too firm, it would not be able to go through. There is no, we don't use an introducer in this. Going through, and then you use balloon it out. It was mentioned how you have to make sure you go beyond the liqueous membranes, both arms, the cephalic branch, balloon goes up. And at this point, that is being done by your assistant. And while you stay still, you widen it through. It is not as quick as what some of the experts have done, but this was with our experience here. Slowly try and make sure that you get to the waist of it. And all this time we're getting irrigation going. We try to widen that a bit more. Just advance that. And once that is done, we are able, therefore, to introduce the scope right through. There are bits of the membrane still there, liqueous membrane, but we are able to see the basilar artery right there. That's an example using the tube. It is not, we don't widen that anymore, but I think purists would say that's a sheath that we use for the endoscope. The next one is using the forceps method. Same route into foramen of Monroe. You can see the choroid plexus. There is Monroe. And I'll just pause that. It is possible, as Mahmoud Qureshi had mentioned earlier, in terms of avoiding damage of the fornix, which is up there. We see the mammillary bodies, infundibulum of the third, and there's the forceps technique. And I think this is what was mentioned earlier using the LOTA. Clear. It is rigid, yes. So if it's quite firm, you'll be able to go through. Advanced. And then it can be widened. You need to have an adequate irrigation system going. Zoomed up, you can see well right through up the base. You can see the basilar artery and the pulsations going, and that's what one would like to see. I think it was mentioned earlier that you will go all the way down up to the fourth ventricle through the Pipontine system, a big pardon. After doing that, that's how things should be able to work. Now, in terms of avoiding the complications, damage of the neural structures. You really need to know your anatomy, as was mentioned earlier, get the direction correct for the residents and for people who are not using things for securing it. Not much movement needs to be secured. For hemorrhage, if you do get little bleeds, you try and make sure that you give a lot of irrigation, and majority of the leakage tends to stop. The only problems are if you go through the flow of the third ventricle and you unfortunately have a catastrophic hemorrhage either from the basilar artery or spia cerebella, then that is a tragedy. Infection, we avoid that, the usual cleaning techniques. And as far as CSF leakage is concerned, when you have done the burr hole, what we try and avoid is you do an elliptical incision with only the pericranium, but when you are withdrawing the endoscope, you pack that using the Surgicel along the route. In terms of morbidity, if you are too close, sometimes it is possible to affect the pituitary axis. Neurological damage can also occur if you get the fornix and or the surrounding vessels. From the point of view of the techniques, we are lucky here that we've had the OI endoscope, which we have utilized. This has given us the opportunity to work it throughout the region. In the University of Nairobi, they have a flexible endoscope, which has been utilized also. But that is how we'd be able to take it. Now, that picture is of the glacier on Mount Kenya. Because of the work that we did with the Neurological Society of Kenya to be able to get the first rigid OI endoscope to enable us to start on this voyage. I've gone quickly. If you've got questions, comments at this point in time.
But whenever you have uncontrollable bleeding with irrigation, the first, of course, you have to irrigate a lot of irrigation. But currently we have the small chamber technique or closed chamber technique and the dry field technique. These are new two techniques to control hemorrhage. Of course, I'm not suggesting to use these techniques to control any type of bleeding. You do not have to say that I will do the dry field technique to try the technique. No, it's not the proper way to think about it. But whenever you have some sort of bleeding that is not controlled with irrigation for, let's say, 20 or 30 minutes, you can just skip for this dry field technique, which is you suck the whole CSF and the whole blood. Then you sometimes this is enough to control the bleeding and the coagulation process control the bleeding, or the other times which are very much more rare, thanks God, you can just start with the point of bleeding and cauterize it. The other technique is the closed chamber technique, and especially with the system where you have the sheath, the irrigation sheath separable, you can just introduce the sheath proximal to the site of bleeding and get the scope out so that you can just compress with the sheath the point of bleeding, and then you can just introduce your electrocautery to this point of bleeding. Again, these are a little bit advanced technique. It's not better to use it in the first or third or maybe the 10th case, but it's better to know these techniques because they are already published and you have to already use them.
I think before one goes on to that stage of doing that procedure, the teaching needs to be irrigated
irrigate, and it will settle.
Yeah.
And so I think only if you've noticed this, despite irrigation, the redness is increasing rather than reducing. That's the final one. Is some of these, and most commonly, the bleeder comes from the pubescent area, and in that situation, it's quite effective to reintroduce the Fogarty balloon and keep it filled up, inflated, and
Some sort
and
of
then the
pressure.
three common P's: patience, pressure, and prayer.
Yeah.
Finally,
Yeah.
we need to stop. So I think with that, unless you have anything else, that's excellent demonstration of technique.
Yeah, I think just as a belt and braces, sometimes if you've done all those layers, a little bit of tissue glue at the end can also help. But by that time, if it has gone through all the tissue glue, that will not hold very much. But yes, as a belt and braces. Yeah.
Has the age limit changed for this? Are you doing younger and younger patients, or do you still have a limit, age limit for this?
I think the age limit for ETV, as we have proven, 6 months is really the cutoff. And if you do it before, the chance of it working is very slim. So why do it? So I think it's still 6 months.
Now, there's a slight difference in our thinking. The thing is that if you look at Ben Wolf's publication, when he did them under 6 months, even with meningomyelin, we had a 33% success rate. So in our setting, because of the problems with shunts, when I go out to do the outreach endoscopy and ETV, I tell the parents, even if it's a month-old child, that because of the problems of shunting, and because there is a 1 in 3 chance that it will be possible that you will get away without a shunt, I am going to offer you the shunt. And working with our colleague in the peripheral hospital, say we will be doing our next mission in about 4 weeks' time. And if it hasn't worked, then we will have another look. And if the osteum is good, that means there is no adequate absorption. We will proceed to a shunt. So for that reason, I have and it's been published in Neurosurgery as well. Our experience with these, we tend to offer shunts earlier and earlier, and also that led us to the discussion on the African Federation of Neurosurgical Grading. Ben Okanga's dissertation and published a paper on that has shown that the variations are just as important in determining success of ETV. So if you've got a grade that has got a lot of multicystic hydrocephalus, has got a lot of scarring, and so even if the child is above 2 years, it'll be a problem. And you're more likely to succeed if you are in the lower grade where your CSF, where your floor, your third ventricle, your walls are all pristine. So those are determinants. So as a result of this combination of our trying to promote the African Federation Neurosurgical Grading System, and the fact that we've had this publications from Ben Wolf as well, where even with meningomyelin, 33% were successful. We tend to use it as a first-line treatment earlier and earlier, because shunting is good. I think it saved a lot of life. But in our setting, and again, the publication comes from a study at the National Hospital, where we had shunt infections and blockages in 33% of the cases. Now,
3% shunt infection is a huge problem. And in our setting, we seem to have very high rates of infection. Once you get a shunt infection, that child is doomed, and that family is in trouble for a long time. So we tend to advocate endoscopic ventriculostomy as a primary procedure, regardless of age, and our results have borne that out, that we do get away in somewhere between 30 to 40% in the very young without a shunt. So why shunt? Yes, you get away. But then the parent must know that they may end up having to have a shunt if it doesn't work in about 3 to 4 weeks.
And what's your experience about right breast authorization? Yeah.
I was trained with Shazuo Oi, and you should see the way he becomes.
When you tell that.
The moment you say CPC, his blood pressure, his facial expression, all changes. Yeah. And the reason is understandable. CSF is not a water bag for placement into the vesicles. It has a function. We do not understand CSF dynamics 100%. There is the pathway that goes through the extra ventricular system. It's a recognized pathway. And I believe, and I think Shazuo agrees with that is actually the sewage system of the brain. And you need that CSF to wash away those toxins and the other things that are all the harmful metabolites or whatever they are, to wash them away. So it has a function. The only time I would advocate CPC is in a very significantly excessive hydrocephalus, where you're only doing it to assist the mother for nursing. So you do that and you do a CPC, it's belt and braces, but as a standard cure for obstructive hydrocephalus, I'm not in favor. I have used it, but
How many cases?
in my really not more than 5.
Yeah, because I had this experience. I used it for 4 cases, and unfortunately, I had 50% mortality. I don't know. There's no explanation. We don't have postmortem. So,
The best result of
yeah, no.
they're not more than
But I agree with you regarding the cases of hydrocephalus.
I think that's more from a nursing perspective.
Yeah.
And we have used that in one of our regional experts is in Tanzania, Shabani, and he does them beautifully. I demonstrated them very well, and I picked the technique from him. I did not go to Ben Wolf. I picked the technique from him. Have used it in those 4 or 5 cases that I mentioned, but I'm not an opponent or in favor of CPC. I have to. I think we have to see it. Not quality.
Exactly.
You don't know what's happening. But no.
Yeah, even there are some recent studies about the CSF dynamics and circulation against our solid knowledge, because they are saying that it is in a reverse way. It's not the imaging studies with the radioactive isotope and this, So still, we don't know the proper CSF dynamics and the proper CSF physiology.
There's an Italian gentleman who I listened to, who is not a neurosurgeon, but a researcher on CSF dynamics. Really, listening to that lecture was convinced me that we were on the right line by not pursuing the CPC line very strongly. But for those who do it, good luck. But it's not something that I favor.
Thank you.
Yeah.
Your presentation made a lot of discussions. Yeah.